Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thank you, Brian, and hello, everybody. So I figured, as some of you may know with regards to ID Week, the National Conference for Infectious Disease Society of America, oftentimes I find that there's a lot of great talks and less sort of new data. Oftentimes at CROI or IAS, we see a lot more new data. However, that being said, I figured that I would, for the purposes of this talk, kind of focus on long-acting injectables, especially since the more real-world data we receive, I think the more informed we are about giving long-acting injectables in clinic. And so with that being said, I've picked two posters and then one oral abstract that was done. I will be using medication names, and I am going to try and only say the generic. And I have no conflicts of interest or relationships to disclose. So these are the three abstracts that I was going to talk about. One is about cabotegravir rilpivirine failures, which I will abbreviate as CAB-RIL, probably just for ease of speaking. And these are failures that were seen at a clinic. Then we're going to switch gears to talk about the Owen Clinic in San Diego, where they share outcomes from implementing injectable CAB-RIL for people with adherence difficulties. And last, conversation from Mississippi, where they shared their experience combining cabotegravir and rilpivirine long-acting injectable with lenacapavir. So first, this is the one from Henry Ford Health, which is in Detroit, Michigan. And for background, I will sort of talk about background for each of these. We know that from the Atlas FLAIR and Atlas 2M studies that long-acting injectable cabotegravir and rilpivirine is efficacious and is FDA approved for those with viral suppression. And from those studies, and predominantly from Atlas 2M, which as a reminder was using CAB-RIL Q8 weeks as compared to Q4 weeks, as was done in Atlas, we saw that the virologic failures occurred at a rate of 2.3% in the every 8-week arm versus 0.4% in the every 4-week arm. And although virologic failure was rare, when it did occur, it was accompanied with pretty decent or high level NNRTI and integrase resistance. So that's a bit of the background. So here, from their study of a retrospective cohort analysis from August 21 to March 23, they looked at people with HIV greater than 18 years at their health system, Henry Ford Health in Detroit, and took individuals who were suppressed on ART for at least 6 months, who then were placed on long-acting injectable CAB-RIL, and then they made sure that those individuals had 12-month viral loads that were available. And they looked at two outcomes primarily. One was virologic failure, which they defined as a HIV RNA greater than 30 on 2 occasions, 4 weeks apart. Now, I think a lot of us would think virologic failure would be more like a RNA greater than 200 as compared to RNA greater than 30, but this is what they opted to pick as their virologic failure criteria. And then CAB-RIL-pivirine failure, which is essentially discontinuation, where the regimen was stopped after greater than 1 dose for whatever reason. So in their results, they had 58 people with HIV who started long-acting injectable CAB-RIL. 49 out of 50 had virologic data at 12 months and achieved viral suppression. And I think a theme that you will all see during these 3 abstracts is that some of the numbers are missing, or rather, when I did the math, I couldn't quite figure out exactly where certain individuals ended up. And so there's sometimes where I'm like, this is what happened, but I really want to know where did those individuals go or whatnot. And so it's hard from these abstracts to get a lot of the data. And obviously we need the sort of final analysis. Of these 58 individuals, it was mostly middle-aged Black men. Of this cohort, interestingly, 52% had a BMI greater than 30. And that's significant because, as you know, we've talked a lot about sort of body distribution and when medication goes into a certain body BMI. And also we know from Cottrell that having a BMI that is higher may be associated with virologic failure when paired with another risk factor. And then also in this cohort, 21% had a BMI greater than or equal to 35. But I did not see a range. And so I was curious, are these individuals with a BMI of 36 or individuals with a BMI of 70? We do not know that. The mean number of years with HIV was 17. So this is a relatively treatment experienced cohort. Remember, these were individuals who were virally suppressed. Of them, again, I mentioned 50 had virologic data. 5 discontinued long-acting injectable Cabril. 2 were due to injection site reactions. 3 were due to virologic failure. Again, the math doesn't quite add up, but I'm going to move on. And because to the slide that I think is really impactful and hopefully helpful for all of us. They looked at those 3 individuals and looked at virologic failure in those people. And I think many of you have heard me say that there's a lot that we can learn from the people who failed to figure out what they failed with, what resistance they failed with, and why they failed. So if you don't mind me taking you through the 3 individuals, as you can see, columns here, or in the rows 1, 2, and 3. And on the left, they have their pre-treatment genotypes, which you can see for patients 1 and 2, there was no genotype performed. But for patient 3, they did do a genotype and there was no pre-treatment NNRTI RAMs, but there was a G140R with regards to INSTIs. And then on the right are their post-treatment genotypes, both with regards to NNRTIs and INSTIs. And I initially started to remake this table, but I actually just wanted to keep this there for you all to have instead of modifying it. Because what I thought one interesting thing is that here, if you look on patient 1, they got a genotype in August 23, and then they got another genotype in December 23. Did the person continue on Cabril? I'm not sure. What happened? Did they stop? But then they got that other genotype. And interestingly enough, the INSTI RAMs were not present there. So I wanted to highlight this because timing of a genotype does matter. And then here's a bunch of numbers. And this is what I wanted to sort of highlight is like, what do these resistance-associated mutations mean? So if we start on the left-hand column, the NNRTI resistance mutations portend a lot of rilpivirine resistance, as you can see. So this is high-level rilpivirine resistance that people failed with, scores anywhere from 45 to 75. And then on the right hand column is what happened with regards to the INSTIs. Number 1, there was minimal decrease to the CAB score. And then for patients 2 and 3, the CAB ratigravir scores were high. And then there was also a high score for bictegravir and dolutegravir. So if a person is failing, they're failing with high-level NNRTI and INSTI resistance. And what that means is that, okay, we can't use the NNRTIs usually, but then I think there's a big impact that you would at least have to BID the dolutegravir if you were going to still use an integrase inhibitor, or perhaps not use it at all. So the summary from this first abstract is that in a retrospective cohort at Henry Ford Health of 58 virally suppressed people with HIV, starting injectable Cabril, 49 had viral suppression at 12 months, 8.6% discontinued Cabril, and of those who discontinued treatment, 3 had virologic failure. Oops, I forgot my failure, with treatment emergent resistance and high-level NNRTI and INSTI RAMs. And 1 patient, patient 3, developed virologic failure with a pre-existing G140R despite on-time injections. So I just want to make an aside on what is this G140R. Per the Stanford Resistance Database, it's a non-polymorphic mutation, so it's a mutation that was seen in macaques who were on long-acting cabotegravir for PrEP. And then also there's at least 1 case report of an individual who had this and they had a mutation score of 60 with regards to cabotegravir. This is a new mutation for me, I must admit, and it's timely because earlier this week in clinic, we had actually ended up getting an archived genotype, which we can talk about whether or not that's needed, yes or no, on an individual in whom the G140R was seen. And it was, interestingly enough, not in the archived genotype, but in the small print. And so as a result, we had decided with that score, we do not want to put this individual on Cabril. And then when I saw this abstract, I felt validated for not doing that because as you can see back on this slide, patient number 3, they had a baseline G140R. And essentially, in my opinion, I think the CAB was not really efficacious. And so then I'm not surprised that the person failed with high-level NNRTI and high-level INSTI resistance. So moving on. Outcomes from the Owen Clinic in people with HIV with adherence difficulties. So the Owen Clinic is in San Diego, and this is their clinic's description of what they've done. So for background about people with adherence difficulties, I think we can all agree that adherence to a daily lifelong medication is difficult. And based on a couple of different studies, I would say at least 50% of individuals with HIV in the US have adherence difficulties. Specifically in one cohort of 170,000 individuals, 43% had poor adherence, which was described as taking less than 80% of your meds, And then another like 30 or 40% had suboptimal adherence, which was less than 95%. So 80 to 95% adherence to meds. So all this to say, it's very hard to take a medication. We know from the Croy report back last year that the Latitude study was the first clinical trial in persons with adherence difficulties. And there it showed that long-acting injectable Cabril every 4 weeks was superior to oral standard of care, which led the Drug and Safety Monitoring Board to halt randomization and offer switch to the injectables to all patients. And then in March, the IAS USA, and then in September, the Department of Health and Human Services updated their guidelines to reflect this. And specifically, this is what the HHS panel says, that they recommend the use of long-acting Cabril on a case-by-case basis in select individuals with persistent virologic failure, despite intensive adherence support on oral ART, have no evidence of resistance to Cab or Ril, and with shared decision-making between providers and the people with HIV. So first abstract I talked about was virally suppressed individuals. This abstract is now about people who have adherence difficulties and may or may not be suppressed. So this was a retrospective or observational study at the Owen Clinic of 63 people with HIV with adherence challenges who started on injectables November 21 to September 23. They defined an adherence challenge as someone who had a viral load greater than 200 in the prior 12 months and poor response to oral ART or lost to follow-up. And their outcomes were similar to the first study: discontinuation of the medication or virologic failure. Their clinical characteristics: of those 63 people were eligible for their 24-week outcomes, 54 people were eligible for their 48-week outcomes. So we have some data from 2 time points. And their cohort was mostly middle-aged white men. 40% had any IV drug use history. 40% had any active substance use, and it was predominantly meth. And 57% of these individuals had a neuropsychiatric disorder. 65% of them were on Medicaid, and this was a relatively treatment-experienced group, 13 to 14 years since having HIV. 40% of them had a viral load greater than 50 at initiation, and 11% had a viral load greater than 10,000. So mostly lower levels of viremia, and they did occasionally give people medications, typically oral meds, to kind of help bring the viral load down. So this is different than the Latitude study where people had to sort of have an induction with an oral and then switch to injectable a bit. But this is just kind of, they gave some meds here and there. This is complicated in my opinion. They had 63 individuals, 51 stayed on it, 12 stopped, 6 stopped, 6 had virologic failure, 3 resuppressed, and went back into this pool of 54 who continued until 48 weeks. I personally did some math and don't think that this is 81% were suppressed at the end, because if you do 44 out of 63, that's closer to like 2/3. So again, the math's hard here for me as well. So logistics of these outcomes, and I figured this is here for a resource for you all, but this is the stuff that I think was sort of key. 14% of these individuals had an oral lead-in. 95% of them did Q8-week injections. Recall that in Latitude, it's Q4 weeks. And 15% had late injections. So relatively on time. Of these 63 individuals, 51 were still on therapy at 24 weeks, and 44 was still on therapy at 48 weeks. So there is a drop-off. In total, based on my math, 19 people at the end of therapy had either stopped or had virologic failure. 8 total had true virologic failure, and 11 total had discontinuation. They only shared data about these individuals from the 24-week cohort and not the 48-week cohort. So again, if you're saying, Jehan, the math doesn't add up, and what happened to these individuals, I do not know. And that was not described in the oral abstract. And then we do not know what mutations the individuals who had failure failed with. They did do a multiple logistic regression, and they found that there were 2 patient characteristics associated with failure. One was having a low baseline CD4 count. So the higher your CD4 count, the more likely you are to stay on therapy. The lower your CD4 count, the less likely you are to stay on therapy. And then substance use was also associated with virologic failure. So the majority of people with HIV in this cohort maintained viral suppression after starting long-acting Cabril. Only low baseline CD4 and active substance use were associated with failure, and 9 individuals had virologic failure, and 11 individuals discontinued therapy. So this is the last abstract, which is the combination of Cabril plus Len in Mississippi. And I think the thing I was most nervous about was whether I spelled Mississippi right or wrong. I think it's right. So for background about lenacapavir, which I think we've all heard a lot about, first in class capsid inhibitor administered sub-Q every 6 months for multi-drug resistant HIV, informed by the Capella study. And actually at ID Week, just a few weeks ago, we got 156-week data that showed that len, when combined with an optimized background regimen, led to high and sustained viral suppression in heavily treatment-experienced people with HIV. And then at CROI, we had seen that we had 34 patients from 4 different clinics who used off-label len and CAB plus minus RIL, and 94% of those individuals had viral suppression. So just one slide on this cohort of 9 patients from the University of Mississippi with either NNRTI or INSTI resistance, prescribed Q2 month IM CAB RIL without an oral lead-in and sub-Q len every 6 months. The mean the mean viral load was 36,000 copies per mil. The resistance history was that everybody had rilpivirine RAMs. One person had an INSTI RAM, and they had a CAB score of 30. But their outcomes, anywhere from 24 to 36 weeks, showed that all people maintained a viral load less than 200, that people's CD4 counts rose. If you were less than 200, they had a 208% increase. And that fits with the lenacapavir 156-week data, in which they saw that people over 156 weeks, which is 3 years supposedly, had a CD4 rise of about 164. And then no treatment emergent resistance was seen. So in sum, based on these abstracts and other things, the majority of people with HIV on CAB-RIL in clinical practice are maintaining or achieving viral suppression, including in individuals with adherence challenges, that discontinuation rates and virologic failure rates are higher in these cohorts than those seen in registrational trials, and that last, the combination of len with CAB and or rilpivirine appears efficacious, though we need more robust data to confirm if CAB and or rilpivirine is a sufficient optimized background regimen.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.